Please help me welcome Dr. Charles Billings.
Thank you so much. It's a pleasure to be with you all this morning. As Rick said, we're going to make an effort to talk a little bit about the biological aspect of the mental health conditions that you all will be dealing with in your careers, looking particularly at the prescribing of medications. The handout that goes along with my lecture is pretty extensive, and because of time, we won't have the opportunity to go over all the conditions. What I think I'm going to do is focus on depression, bipolar disorder, anxiety disorder, and then depending on time, perhaps insomnia. So that's kind of the quick introduction, and let's go ahead and get started. As you all know, there are different types of depression, major depression being the most severe, major depression being the form of depression that causes basically a shutdown of the ability to engage in normal personal, professional activities. Typically, major depression is the one that we think about treating with medication. And let me go ahead and introduce the biopsychosocial concept of all psychiatric conditions. By that I mean the biological part is the part that has to do with brain dysfunction, neurotransmitter dysfunction. The biological piece of depression consists of symptoms such as low energy, blunted libido, problems with sleep, effects on appetite. The psycho part, the psychological part, has to do, of course, with the emotional symptoms, loss of pleasure, loss of enjoyment. But the biopsychosocial model applies to all psychiatric conditions. The more biological a person's symptoms are, the more likely medication is to be prescribed and to perhaps help. The more psychological the symptoms are, the more likely that psychotherapy or counseling will be necessary. Every person that we see falls somewhere on this spectrum, but they vary in terms of the percentages. For instance, somebody that I might see in my office might have an 80% biological component to his or her depression and 10% psychological, 10% social. So that's a person that's going to typically need medication before he or she can respond and get better and move on. On the other hand, someone else may have just 20% of a biological component, and much more of their depression has to do with stressful life events. That person is not going to go into remission until they get psychological counseling or therapy. And the way we make these distinctions, and obviously they're very rough in terms of the percentages, is to look at the degree to which the symptoms are endogenous or biological. That is the physical component, that's the biological piece, and that's what we're going to talk about today with each of the conditions that we're going to address. A question comes up about prescribing antidepressant medicine for major depressed patients, and I'll address first of all, how long do you keep a patient on their antidepressant medication? And this alludes to the concept that most people with major depression have a recurring illness. By recurring, we mean they'll have an episode that will typically last 4, 6, 8, 10 months, and then often that episode improves, sometimes even without treatment. There'll be an intervening period where they are relatively back to their baseline before perhaps another episode may come along, a second episode. For some people, up to a half dozen episodes. So over the course of a lifetime, major depression basically comes and goes. And that is significant in terms of how long to keep patients on antidepressant medication. The medicine is prescribed. Hopefully they will go into remission of their symptoms. We'll come back to the concept of remission in just a few moments. And the recommendation for the first episode of depression is a minimum of 6 months. We've got data that if a patient takes their antidepressant for 3 months, gets better, and then stops, the likelihood of them sliding back into depression again is extremely high. And that's where the 6-month concept comes from. After 6 months, there's a greater chance that they might be able to be tapered off and remain symptom-free. So 6 months is kind of the minimal target for the first episode. If your patient, though, is having his or her second episode of major depression, here the duration of treatment should be longer, at least a year, perhaps 18 months. Here again, stopping sooner than that's going to likely lead to a recurrence of the depression very quickly. And then one might consider coming off. If it's your patient's third episode of major depression, the recommendations are indefinite prophylaxis. If your patient is on his or her third episode, their likelihood of having a subsequent episode is 90%. So they need to be on lifetime prophylaxis to protect them from further episodes of depression. So 6 months, 18 months, and these are rough percentages, of course, and then indefinite lifetime use of the medicine if they have a third episode or greater. We've already addressed a little bit when to prescribe medicine versus psychotherapy. The more psychological and social these symptoms are in terms of their origin and their impact, the more the person is to likely need therapy with medication. There's lots of data that strongly suggests that a combination of medicine and psychological counseling works better than either one alone. I do see some patients who say basically, I think I need therapy and I need medicine. Let's do the medicine first. Then once I'm feeling better, I want you to give me the name of a counselor. And then after 2 months on the medicine, their symptoms go into remission. And they say, well, gosh, most of the things that I thought I needed therapy about have evaporated. These people are ones who might have 80, 90% of their depressive symptoms being biological in origin. And the medication basically got them into remission, and the need for therapy is less. Other people, though, either have a more modest response to medication, or you might even decide up front this person doesn't even need medicine, they need to go right into therapy. So that's one of the assessments that you'll make from the beginning, keeping in mind again that the combination of the two is better than either alone. But of course, in the real world we live in, then we get into issues of cost and accessibility, which of course can make that a difficult decision. Remission in the treatment of depression means the patient returns to his or her baseline. They aren't less depressed, they become undepressed. And that's not good English, but you get the point. Response is basically defined as roughly a 50% improvement in their symptoms. And there are rating scales, of course, that can be used. I'll often use just a very simple 1 to 10 scale in the office, where I'll say to a patient, on a 1 to 10 scale, where 1 is the way you felt when you were rock bottom depressed at your worst, where are you today after a month of being on this medication? If somebody says, gosh, I was at 1 a month ago, I'm probably about a 4 or 5 or a 6 now. That person is responding. They are better. They're getting some impact from the antidepressant. But the next question is, but what's missing? What still needs to change or get better for you to get up to 8, 9, or 10? Because 9, 10 is where we want to get them. That's the remission point. And if they're at 4, 5, or 6, you're not finished yet. This is important because the FDA, when it's evaluating new medicines that might be potential antidepressants, only requires a 50% improvement in the various rating scales they use, the Montgomery-Asberg Depression Rating Scale, the Hamilton Rating Scale. But think about it, if you or a sibling or a spouse or a good friend is very, very depressed and they're 50% better, that means they're 50% still depressed. And that's not adequate. Our current gold standard in treating depression is to get patients back to baseline. We know that we can't always do that, but that still should be the goal in treatment. What happens, what are reasons for doing this? One is that if a person has inadequately treated depression, that is, they're responding, but they're not in remission, there's an ongoing suicide risk. We all know that suicide is a symptom of depression, and if somebody is less depressed, but not back to their baseline, they may start to think, gosh, this is as good as I'm going to get. This is as good as treatment is going to affect me. I was thinking of suicide, able to kind of put it aside, but now that I've come for treatment, I'm seeing that treatment can only do so much, and the likelihood of acting on those suicidal thoughts may increase. So the suicide risk is still there. Increased risk of relapse. The longer depressive symptoms remain, residual depressive symptoms, the greater chance the patient may slide back into their original depressive episode. So that's another reason to treat to relapse. Also, if patients don't go into remission, over time, this depression becomes more and more difficult to treat. And one of the biological reasons for this is a fascinating area of research, which has to do with negative impact of depression on brain structures, particularly the limbic system. As you all know, the limbic system is the emotional center of the brain. That consists of the hippocampus, the amygdala, other structures. And over time, lingering depression or recurring depression will basically eat away at the integrity of the limbic system. And the shrinkage of the hippocampus has been shown in serial PET scan studies of patients whose depression lingers and has not been treated into remission. And the reason the shrinkage occurs is literally the atrophy and or death of neurons. There are peptides in the hippocampus whose job it is to work, as it were, like fertilizer to keep those neurons healthy and functioning. And that's one of the exciting things, that patients who have been taking antidepressant medication and had hippocampal shrinkage, over time the hippocampus may shrink back to the normal size again, showing a plasticity of the brain that we never really knew was there before. But that's one of the reasons that depression, the longer it's there, becomes more and more difficult to treat, and one of the reasons for being very aggressive up front about treating to remission. Especially this is important for younger people. somebody's 22 years of age, often their depression may be trivialized, as in, oh gosh, you're in school, you're having trouble with your family, that must be the reason for depression. Either you don't need medication, or I'll give you some medicine to, quote, take the edge off, unquote, but not treat all the way to their baseline. And there again, as we've just talked about, there are potential negative consequences to trivializing that impact of major depression on the person's brain as well as their life. Let's move on to the different antidepressant classes that we have to select from. And this leads us into just a quick comment about neurotransmitter activity in depression. We all hear about serotonin a lot, norepinephrine, dopamine. These are just the three most common ones that we talk about, but there are dozens of neurotransmitters in the brain that regulate our mood. But the very common SSRIs standing for selective serotonin reuptake inhibitors, are antidepressants that work primarily or solely on serotonin. So if you look at the list of SSRIs, you see lots of familiar names there. I won't run through the list, but these were the first new antidepressants that came out roughly in the 1990s. The old tricyclic antidepressants were prevalent before that, back in the 70s and 80s, and the SSRIs came on the scene in the 1990s. And the revolution that they brought to us was intolerability. The SSRIs are no more effective against depression than the old Elavils and Sinequans and Tofranils, the tricyclic medicines from the 1980s. The difference, though, is in their tolerability. Much less likely to create unpleasant symptoms of dry mouth and blurred vision and weight gain and constipation. And obviously, if patients have significant troublesome side effects, they're either not going to take their medication or they're not going to take adequate doses of their medication. And that was the breakthrough with the SSRIs, is bringing an improved tolerability to the scene where patients would take the medicines and have a better chance of responding and or remitting to it. So after a few years, though, of using Prozac, Zoloft, Paxil, we had an antidepressant called Effexor, or venlafaxine, come on the scene. And this was a serotonin and norepinephrine reuptake inhibitor. Now, what does norepinephrine do? If serotonin works on mood and anxiety, norepinephrine underlies energy and cognition, as in attention, concentration, and so on. And so the SNRI family you'll see here, Effexor, Cymbalta, Prostiq, Savella, Fetzima, these medicines combine activity with both serotonin and norepinephrine. And why is this important? One thing we noticed in treating patients who were depressed with, let's say, Zoloft, was that they would come and say, I'm less depressed and I'm less anxious. I don't want to kill myself anymore. I feel more like going back to work and doing things that I stopped doing with my depression. But I still don't have the energy, the motivation, the get up and go that I used to have. I still can't concentrate and pay attention like I used to do. And one of the things we would do that we'll get to in just a moment is to add Wellbutrin to that serotonin medicine, because Wellbutrin works on norepinephrine and dopamine. So you bring the norepinephrine dopamine effects of Wellbutrin added to the serotonin effects of the Zoloft, and you diversify or expand that mechanism of action. So not only are you treating depressed mood itself, but concentration, energy, get up and go a little bit as well. So we've learned that for many patients, the underlying biochemical components of their depression is indeed heterogeneous. And there is some data that the broad spectrum antidepressants like the SNRIs may have a higher response or remission rate than just pure SSRIs, because they're hitting more neurotransmitter activity than just the serotonin drugs alone. In fact, there is data that goes with venlafaxine XR, pooled data that's about 15 years old now, that it may have beaten, in effect, in remission rates, lots of the traditional SSRIs because of its serotonin norepinephrine activity, and even at high doses, a little bit of dopamine activity. And that would be one of the considerations that would come into play if I see somebody who comes in and says, I've been depressed for either quite some time, or this is my third episode of depression, and I've been on Prozac, and I've been on Paxil, and I've been on Zoloft, and all of them maybe helped a little bit or didn't help much, but I'm depressed again, what are we going to do? I'm not going to pick another serotonin drug, because their lack of response or remission suggests that serotonin only is not in play here. We need to employ a more diversified neurotransmitter approach, and that's where an SNRI then might come into play. We've already alluded then to norepinephrine and dopamine, and that's where Wellbutrin or bupropion comes in. Aplenzin is just another brand name for bupropion. But there was the old original Wellbutrin, which was 3 times a day, then Wellbutrin SR, which was twice a day. But the one that we use the vast majority of the time these days is Wellbutrin XL or bupropion XL. This medicine works on norepinephrine and dopamine only, no impact on serotonin. So what does that mean? It means that bupropion is not very helpful against anxiety, because anxiety is very much serotonergically mediated. And that's why many patients on SSRIs are less anxious and less depressed, but don't have energy, concentration, motivation effects that a Wellbutrin might bring. But now you can see why that combination of perhaps a Prozac and a Wellbutrin might be relevant for lots of patients to, again, diversify the neurotransmitter activity. The drawback of combining antidepressants, of course, is 2 medicines to keep up with, 2 medicines to pay for, compliance issues perhaps, side effect issues perhaps, but there's lots of data and lots of clinical response that shows that that's often a good idea. And again, if we're going to treat to remission, somebody that says I'm less anxious and less depressed, the 50% improvement on Zoloft may be enough. But if we want to get them up to 8, 9, or 10, they may need Zoloft and Wellbutrin together to get them to that point. I mentioned earlier the old tricyclic antidepressants, and this is the list of them that you'll see. The tricyclics were very effective antidepressants, but it required typically high doses that were quite laden with side effects. And for that reason, they have fallen very much out of favor, except for patients who may be treatment resistant to some of the newer antidepressants. 2 antidepressants that we still do use fairly often, though, are nortriptyline, which is Pamelor, and desipramine, which is Norpirmin. Those are probably the 2 best tolerated of all the old tricyclic antidepressants. Elavil, or amitriptyline, is often used in low doses for pain, either pain as in disc disease, disc compression in the lower back, or even with migraine headache prophylaxis, even to treat diabetic neuropathic pain. When you combine serotonin and norepinephrine activity together, you get a mild to modest analgesic effect that can be very effective. So that's where its biggest use these days is probably as an analgesic medicine. Other antidepressants, Surzone is not prescribed a whole lot anymore, mainly because of data suggesting that it may have an increased likelihood of liver toxicity. But with that one huge but unfortunate side effect, lots of benefits because it's very low in sexual side effects. It's very calming and composing, and you'll still see patients who are taking that. Trazodone or Deserel kind of failed as an antidepressant when it came out, mainly because of its primary side effect, which was sedation. People on Deserel said, yes, I'm less depressed, but I want to sleep all day long, so obviously not really a keeper for people that want to function normally. But that has led to Trazodone's current use, which is as a sleeping agent. In fact, Trazodone is the most widely prescribed sleeping medicine in the world. Reasons are it's generic and dirt cheap, number 1. Number 2, it's not a controlled substance, so no issues of tolerance or dependence. Number 3, it's actually better at keeping you asleep than it is at putting you asleep. So lots of patients say, I can go to sleep, I just can't stay asleep. I'm waking up throughout the night, have fitful sleep, and that's where Trazodone, partaking of its antihistamine effects, its sedating side effects, may be a real help in terms of treating their insomnia. Vibrid, a relatively new antidepressant that combines serotonin reuptake activity with activity on a particular receptor, the 5-HT1A receptor. I just mentioned that to make the point that whenever you diversify mechanisms of action, you may pick up 1 million people, let's say in a country over here, that might respond to that new mechanism of action that have not responded to more traditional mechanisms of pure serotonin reuptake activity all by itself. And that's the response to people that say, do we still need new antidepressants? And the answer is absolutely yes, because as we'll get to again in just a moment, we still are doing a woeful job of treating to remission. Most people on antidepressants get better, but not nearly enough go into remission. In fact, the current remission rates are around 33-35%. And think about what that means. Again, that means that the other 70%, 65% are better, less depressed, maybe not suicidal anymore, but still have lingering symptoms that negatively impact their ability to function normally. All the reason for newer antidepressants, combination antidepressants, and a strategy we'll get to in just a moment called augmentation. Remeron, you've heard of Remeron, mirtazapine, an antidepressant that has two side effects that are both good and bad. The two main side effects of Remeron are sedation and weight gain. So the sedation makes it a good medicine to help with sleep. The weight gain causes it to be not so good for people obviously trying to control their weight, be healthy, and function in the real world. But think about potentially a nursing home patient who can't sleep and is not eating, has no appetite. Remeron might be a great choice for them to stimulate their appetite after a week or so, help them sleep better through the night, even have a modest anti-anxiety effect to calm them down. So there again, this is where we're matching side effects to clinical effects, clinical symptoms of the depressed person, him or herself, in terms of selecting the best agent for them. Trintellix is probably the newest antidepressant on the market, and I'll just make a couple of comments about Trintellix. It's fascinating because it is classified by the FDA as other, meaning that it is not an SSRI, SNRI, NDRI like Wellbutrin. It works on serotonin reuptake, but it has multiple receptor activity that may regulate downstream histamine, GABA, norepinephrine, dopamine, and a number of other neurotransmitters, glutamate, that may be involved with mood. And there also is data that Trintellix may have double the remission rate of some of the other antidepressants. One study showed a remission rate of Trintellix of 61%. And remember, I mentioned earlier that remission rates of lots of other antidepressants is in the low 30s. So keep in mind Trintellix, expensive because it's still new and not available in generic, but for treatment-resistant patients might be an excellent choice for that very reason. So-called natural agents. People often say, gosh, I don't want to take a chemical for my depression. Is there something natural? Well, that's obviously a little bit of a misnomer because all our so-called natural agents are also chemicals. They just aren't FDA-approved, typically medications for depression. But Deplin is methylfolic acid, methylfolate, and you should know about Deplin. Deplin is actually manufactured in Louisiana on the North Shore. Methylfolic acid is a precursor in the brain of serotonin, norepinephrine, and dopamine, the three neurotransmitters we've been talking about that do have a role to play in many depressed patients. So by taking Deplin, you're providing more of a substrate for the manufacture of the very neurotransmitters perhaps necessary to improve mood. And that's one reason that Deplin seems to be effective for many patients in terms of making their antidepressant response more impactful. Now this is adding Deplin to the antidepressant, not Deplin all by itself. Similar thing with omega-3 free fatty acids. There are a number of studies suggesting that omega-3s may have mild to modest antidepressant effects. St. John's wort kind of falling out of favor, mainly because we found that St. John's wort is an MAO inhibitor. And we know that MAO inhibitors may sometimes have side effects with certain foods, other medications. It's a very mild MAO inhibitor, but it's not as, quote, safe or symptom-free as a lot of people would think a, quote, natural compound would be. So I've never recommended a patient take St. John's wort for those reasons. And lots of recent interest with vitamin D. Vitamin D deficiency to some degree may be an epidemic. It seems like most doctors are now checking for vitamin D levels. And probably all of our vitamin D levels drop this time of the year. We know that vitamin D is manufactured in our bodies in response to natural sunlight. And with the shorter days of the fall and winter time, we are all exposed to less and less natural sunlight. This kind of artificial light doesn't count. And that's why many patients with bipolar disorder get manic in the spring and summer. The extra sunlight, the extra light brings them up out of their depression into a hyper state. But the depressive component may be more prevalent during the wintertime. But all of us have vitamin D levels that may dip in the wintertime. So I'm often recommending vitamin D supplementation to people who have so-called seasonal affective disorder, who say my depression is either worse in the wintertime or that's when I get depressed is the wintertime. Adding vitamin D to their antidepressant regimen may be helpful. Talking about a couple of thousand international units, at least, sometimes 5,000. Endocrinologists will use much larger amounts, but 1,000 to 2,000 is safe and maybe still very impactful. I mentioned earlier the concept of augmentation. Let's talk about what this is. Back to my patient earlier on the 1 to 10 scale who said, you know, I think I would give myself a 5 after a month of taking your antidepressant. So they're responding, they're better, but they're not back to the 9 or 10 we want them to get to. Now, my second intervention is going to likely be, let's go up on this antidepressant. If they're on 50 milligrams of Zoloft, That's a starting dose, but many people need 100, 150. So the first thing you do is to maximize the antidepressant and increase the doses. In fact, that's one thing to watch for if your patient is being treated in primary care settings. Many primary care physicians are a little bit uneasy about, quote, pushing the doses, unquote, of many antidepressants, whereas psychiatrists in general are much more comfortable with that. So that would be one consideration in terms of just helping them to make treatment decisions about what they're going to do. But you always optimize the dose of the antidepressant first, because it's always ideal, of course, to be in remission on one medicine rather than having to take two. But let's say you've maximized the dose. You've pushed Zoloft up to 200 milligrams per day. Person says, well, maybe I'm a 6 now on that 1 to 10 scale, but I'm still not back to where I want to be. What do you want to do? If you change to another antidepressant, you got a 6 on the 1 to 10 scale now, and the next antidepressant might get the patient only to 3 or 4. You kind of hate to give up that 6. You hate to give up that response. And that's where augmentation comes into play. Augmentation agents are catalysts. They are alternative medicines added to the original antidepressant that increases the activity level, so the patient may then get bumped from 6 up to 8, 9, or 10. And I've got a list here of a number of potential augmentation strategies to use. So yes, this is 2 medicines, but if the 2 is doing a lot better and a lot more than just the 1 by itself, obviously that's a big plus. Now, back to the patient and the 1 to 10 scale. If somebody says, I'm still 1, or I'm only 2 or 3, that really classifies as a non-response. You don't typically augment somebody who is bumped up to a 2 or 3 on a 1 to 10 scale. Why? There's just not a whole lot of impact of that original antidepressant to build upon. And you think, gosh, surely I can do better than 1, 2, or 3 by changing to an alternative antidepressant. So somebody not responding after you've optimized the dose to your original antidepressant, those are the ones you change to a different agent. Those who have responded to at least roughly a 5, though, those are the ones where you may consider augmentation. If you do change to another antidepressant, change to a different class. I alluded earlier to a patient who said, I've been on Prozac, I've been on Zoloft, I've been on Paxil. Well, gosh, their prescribers have been hitting the serotonin system over and over and over again. We've talked about the fact that what if dopamine is involved? What if glutamate's involved? What if norepinephrine is involved in their depressive symptoms? By taking SSRIs over and over again, you're not getting enough diversity of activity to bring that patient into remission. So if they've been on your SSRI and they did not respond to that, I'm going to prescribe typically an SNRI or a Wellbutrin or even a Trintellix with a different mechanism of action, hoping to pick up extra activity that would bring that patient into response and remission where the serotonin activity alone was unable to do that. So we augment when there's a partial response, and here are agents to consider. 3 that are FDA approved are Abilify, Seroquel XR, and Rexulti. These are 3 medicines that have been shown to improve the activity of any antidepressant when added to them. Another huge benefit of these 3 medicines is rapid onset of action. Patients who have Abilify or Rexulti or Seroquel XR added to the antidepressant may see a response often in 4 days, 7 days almost certainly. In fact, if I'm not seeing a response in 7 to 10 days in somebody that I put on Rexulti, I'm going to typically move on to something else. So that's a huge plus, because if this is a very brittle or fragile depressed patient, somebody that still has lingering suicidal thoughts, who in effect says, gosh, we've got to do something fast, I'm not sure I can hang in there, I'm going to have to go to the hospital, to the ER if you can't do something, augmenting with one of these 3 may be a real option because of the rapid onset of antidepressant activity on top of the original antidepressant. What's the drawback of these 3? Cost. Rexulti is still brand name, restricted in terms of many insurances to get to it, and Seroquel XR and Abilify are now generic, but still on many plans you've got to try other members of their family before the insurance will approve those medicines. And I'll just make a comment here. This obviously opens up the whole subject of the control of prescribing practices by the insurance industry. Fortunately, in psychiatric settings, it's often not quite as bad as primary care, because since most of my patients are treatment resistant to begin with, which is why they're coming to me instead of back to their internal medicine doctor, they've already been on 2 or 3 other antidepressants, or may have even been augmented with something else, so they actually fulfill the criteria. Still may mean 30 minutes of paperwork from me and or my staff, but but patients who have not had that treatment-resistant history may not be able to access those meds for a long time. And of course, then we get into what does that do to their life? Obviously, we talked earlier what happens if depression lingers in terms of negative effects, but I won't go on and on with it. You are aware of that. Lithium carbonate. Lithium carbonate, as we know, was actually the first medication used and approved for bipolar disorder. But a lot of people don't know that lithium carbonate is a very effective antidepressant augmentation agent for what we call unipolar depression. Unipolar depression is a person that has recurring depressive episodes but doesn't have the up episodes that a bipolar patient would have. Lithium carbonate added to Effexor, to Zoloft, to Prozac, often again quickly, 7 to 10 days, may bring about a dramatic improvement in mood, and often at low doses. It's also generic and expensive. The negatives of lithium are that it does require blood monitoring, may have some impact on kidney functioning and thyroid functioning. So there are drawbacks, obviously, to every option we've got. But here again, the ability to bring somebody from just a partial response into a more complete response or remission can be seen with lithium. T3 or Cytomel. The major thyroid hormone is T4, or if you've got hypothyroidism, you might recognize it as levothyroxine or Synthroid. That's T4. But T3 is Cytomel, which can also be prescribed. T3 has been shown to be another antidepressant augmentation agent that can help with depression without significantly affecting thyroid functioning. And right now I've got about a half dozen patients where Cytomel added to their antidepressant has given them lots of increase in energy and improved their functioning significantly. I'm going to want to check thyroid functioning over a period of time to make sure that does not adversely react. But again, that is an agent that lots of people are unaware of. Even stimulants, Adderall and Ritalin, can be used as antidepressant augmentation agents in people who are not ADD. Adderall works on norepinephrine and dopamine. So you got your patient on a serotonin drug, and they couldn't tolerate Wellbutrin. They might benefit from adding Adderall or Ritalin to that. The biggest negative, of course, is these agents only last a few hours and aren't 24 hours in terms of their activity, and that would be a limiting factor for them. And you need to know about Provigil and Nuvigil. Provigil's generic name is modafinil. That now has been generic a few years. It's people that have narcolepsy or people who have sleep apnea and are still sleepy during the day despite use of a CPAP machine, or people who engage in shift work and are therefore kind of sleepy all the time. Modafinil, taken in the morning, gives them then about 10 hours of increased alertness, being awake, being cognitively sharper, less likely to be drowsy, and then wears off. It does not work on norepinephrine and dopamine like the stimulants do. It works on orexin, which is a peptide that keeps us all awake. Melatonin is a peptide that puts us to sleep at night. Orexin is a peptide that wakes you up in the morning. And Nuvigil or Provigil work on orexin, a little bit on histamine as well to make you awake and alert. They also may have antidepressant augmentation effects added to antidepressants. I should mention that most of these augmentation strategies I'm talking about are not officially FDA approved. And let me make a comment about that. So you might think, well, gosh, is it legal to do that? Is it ethical to do that? And the answer is yes and yes. What FDA approval simply does is to have a medication screened and studied to show that it is safe and that it can work in a particular condition at certain dosage levels or in certain dosage ranges. Once any medicine gets on the open market, though, a physician or a prescriber, nurse practitioner, physician's assistant, can prescribe these medicines any way that he or she sees fit, as long as it seems to be beneficial and is tolerated. And that's certainly ethical to do. Let's take propranolol, for instance. Propranolol is a beta blocker, originally approved by the FDA for angina and as a blood pressure medicine. Probably the biggest use of propranolol these days is in psychiatry treating PTSD, flashbacks, and lots of other anxiety-driven symptoms, panic attacks and so on. Perfectly safe to do that. It's also used for tremor, essential tremor, Parkinsonian tremor. So again, in case you were wondering about using medicines that aren't officially approved, there's a literature, of course, that is developed once medicines are on the market that guides us in terms of what to perhaps consider these meds for and what the dosage ranges are to consider. What about when the person is primarily depressed, but they're also anxious and they can't sleep? Well, if it's anxious and depressed, I'm going to make sure I'm picking at least an antidepressant that has some serotonin activity. As we said, serotonin is usually necessary to treat anxiety, not always depression, because like Wellbutrin that works on norepinephrine and dopamine treats depression, but not so well anxiety. So if they're very anxious, they're going to get probably Lexapro or Celexa, a good anti-anxiety antidepressant. And in fact, around 70-80% of all depressed patients may have some accompanying symptoms of anxiety. That's one reason that Wellbutrin will never be the #1 prescribed antidepressant in the country, because it just doesn't help anxiety all that much. And since anxiety is so prevalent in depressed patients, they're going to be on SSRIs, SNRIs, at least to start with typically. Sleep is a whole category in and of itself, and just to make a couple of comments, I was taught in medical school something that we now know is not true, which was that insomnia is always secondary to some underlying primary condition, and you treat the underlying primary condition and the insomnia will go away. So the patient can't sleep because they're depressed, they can't sleep because they're in pain, they can't sleep because they have fibromyalgia, they can't sleep for whatever. But we've learned over the years, lots of my patients who are in remission with all their depressive symptoms, but they still can't sleep. Or they no longer have any panic attacks anymore, but they still can't sleep. So insomnia can become a syndrome, a symptom cluster in and of itself. But again, it needs attention, because insomnia untreated, ignored over time, can destabilize, adversely affect mood, concentration, metabolism, the immune system. Lots and lots of attention these days on sleep, the quality of sleep. It's very easy for highly productive people to trivialize sleep and say, gosh, I don't want to go to bed now, there's 2 more hours of work I could do. And we've all been in that situation, especially when you go through graduate school, undergraduate school, medical school, so on. But roughly 8 hours of sleep every night, very important to lead a healthy life. In fact, a recent article was fascinating, I guess I'm diverging a little bit, that said if somebody has an emotional condition, there are 4 things that need to be paid attention to. First is the biological. Are there medicines that need to be prescribed to target and improve their symptoms? Number 2, the psychological. Do they need therapy, counseling, or are they at least engaging in some activities that make them aware of how they may be self-defeating, shooting themselves in the foot, so to speak, and so on. The third is physical exercise, and the fourth is sleep. The first 2 are not surprising to most people, but the fact that physical exercise and 8 hours of good sleep every night had almost the same impact as counseling, therapy, and medication has gotten lots of people's attention. So everybody I see gets a lecture about physical exercise and sleep, besides prescriptions for medications, because of how important that is. 2 years ago, 30 articles in the world's literature about the emotional impact, positive emotional impact of physical aerobic exercise. In exercise, you're burning up all those negative neurotransmitters that make you anxious, hyped, unable to sleep at nighttime, angry, irritable, sad. So to push that and insist on that, even 4 days a week, 3 to 4 days a week, half an hour, can be very, very impactful. So everybody should be doing that along with their medicine, along with their therapy. Very important. Let's jump to number 9, antidepressants and suicide. Just in the interest of time, as we all know, there is an FDA warning addressed to children and adolescents about the possibility that antidepressants may either cause suicidal thinking and behavior or even lead to suicide. And this has been a very controversial ruling by the FDA. It's there because you need to be aware of it. I'm sure you are aware of it, and you'll have clients, patients asking you about it. First of all, keep in mind that that warning applies only to children and adults up to the age of 24. That data showed no instance of people over age 24 having increased suicidal thinking thanks to antidepressants. Lots of clinicians think that the data on which this was arrived at were situations where children and teenagers who actually were bipolar were prescribed antidepressants that stimulated and activated them, causing them to become suicidal. So that it wasn't so much an issue of the antidepressant per se, but the antidepressant being prescribed for an inappropriate diagnosis. We don't have time to go into the whole history of it, so I would never say that this can't happen, but it's incredibly rare for this to be an issue. What kills most patients via suicide is depression, not the medicines we prescribe to treat the depression. Now, if they're inadequately treated, if they're somewhat better, not in remission, that might be a legitimate issue. So don't ever give a patient antidepressant and say, take this medicine and good luck. They need to be followed, monitored, come back to be checked on, make sure they're on the right dose, they're taking it, deal with side effects. So if they say, take the medicine and I wish you the best, that person may go out and kill him or herself, and that creates the impression that the antidepressant was the factor, but it really was, again, inadequate treatment and not being followed up that was the issue. So just be aware of that. The other concern, too, is that we have some data that shows that over the years since this black box warning came out, that the prescribing of serotonin antidepressants for teenagers has gone down, down, down almost every year, and the suicide rate in teenagers has gone up almost every year. So showing that by prescribing fewer antidepressants, we're actually causing more suicides rather than protecting against suicides. That's why it's such a complex and controversial issue. How do you pick the right antidepressant for your patient? First thing, prior response. Somebody says, gosh, I took Paxil before, 30 milligrams a day. It was great. I went into remission in 6 weeks. That patient's getting Paxil again, real easy. These days, cost and financial issues, we've already alluded to that. Everybody initially is going to typically get a generic medication. That's perfectly legitimate. We want to keep costs down if we can, and antidepressants may not be the only medicine they're taking. But as we said earlier, sometimes that first 1 or 2 generics may not work, and that's when we get into the head-butting with the insurance company when we may want to prescribe a branded antidepressant that may have a more diversified mechanism of action. But at least initially, we want to be very aware of cost and be very sensitive to cost. Then we talked earlier about so-called serotonin symptoms with anxiety, norepinephrine, kind of energy and concentration, dopamine being maybe motivation and pleasure symptoms that we may want to target, and selecting the antidepressant that best targets those symptom clusters. ECT is still a definitive treatment for depression. Has a horrible public relations image, obviously. One Flew Over the Cuckoo's Nest a few decades ago just did a real number on ECT. And of course, that's not the way we do it. Patients are treated as an outpatient. They're put to sleep for just a very short period of time. They don't have an actual seizure on the table. They have a muscle relaxant that prevents that from happening. And I've got a patient just completing ECT as we speak. About twice a year, I'll send somebody from ECT who is just not responding to a series of one antidepressant regimen after another. And what I say to patients is, it is rare for a patient not to respond vigorously to ECT. So it's not something we want to leap to too quickly because of the cost and the perception and so on, but it can be very, very effective in terms of its impact. The use of the powerful magnets to treat depression are not quite as potent as ECT, but a lot more acceptable to lots of patients because they just sit there inside of a giant magnet, much like the old-fashioned hair dryers, for a half an hour, 5 days a week. And there is data about that being helpful for depression, so be aware of that. That's still being researched and looked at, but not quite as robust in terms of its response and remission rates as ECT. Ketamine's still in the works. Everybody may know of at least a friend or a family member who's gotten ketamine intravenously. The good news about ketamine infusion therapy is almost an immediate response in terms of depression. I've had 3 patients go to get ketamine infusions because not my recommendation, because it's not FDA approved and it has lots of drawbacks, but they all said it was wonderful in terms of what it did. So what's the problem? The problem is it lasts about 2 weeks. Then they go right back into the depression again, and they can't continue to get ketamine because of its highly addictive nature, lots of other issues. But what ketamine's very robust and immediate response shows, though, is that glutamate system and the NMDA receptors are obviously involved in the depression symptoms of lots of patients, and lots of research is going on now looking at why does ketamine work and how can we now develop a longer lasting and safe and effective antidepressant that would substitute and do what ketamine itself actually does. Bipolar disorder, of course, is a lifelong condition, biologically inherited, where a person has not just depressive episodes like we've been talking about in the people with unipolar depression, but they have at least one episode where they come what we call above the line. Above the line means instead of being down, withdrawn, tired, draggy, they become energetic, racing thoughts, very creative, very spontaneous, perhaps impulsive, hypersexual, decreased need for sleep. And if it's of a modest degree, we call that hypomania. And if it's of a significant degree to the point of leading to hospitalization or having psychotic symptoms, we'll call it mania. And it just takes one such episode to be called bipolar. You can have one manic episode and 15 depressive episodes, but that still makes you bipolar because that shows that the chemical underpinnings of your depressive symptoms are different. And that's really important for this major reason, and we won't go through everything on the slide deck in the interest of time. All the antidepressants we've been talking about, the Prozacs, the Effectors, and Trintellix, none of them are FDA approved to treat bipolar depression. Why? They just don't work very well. The traditional antidepressants don't work in bipolar depression. They either don't work at all, or they're not very well tolerated, or they work for a month or two, and then they poop out and fizzle out. And in fact, that's one of the clinical guidelines I will use to diagnose bipolar depression. Somebody comes in and says, I've been on 4 antidepressants over the last 6 months, and I can only take them for about a week or 2. They just made me feel terrible, or I just didn't get any response to any of them. Makes me wonder, this may be a bipolar patient I'm seeing in the depressed phase, and that's why he or she is not responding to traditional antidepressants. Even if a person does respond somewhat, we want to limit the dose and the duration of antidepressants in bipolar patients, because over time, antidepressants will lead to a kindling process in the limbic system that destabilizes them and causes them to have more frequent mood swings, shorter intervals in between mood swings, and more severe mood swings. In fact, patients that we call rapid cyclers, who may have shifts of mood half dozen times a year, often have a history of being tried on antidepressant medicines for long periods of time, and the antidepressants, in effect, work like gasoline on the fire in a bipolar patient. So that's one reason it's important to make sure that your depressed patient is not bipolar depressed, because that changes what they need to take completely. So what do we give bipolar depressed patients when they're depressed? There are 3 FDA-approved medications. The first was Seroquel XR. And left out of this particular slide, it's down at the bottom, the second one is Latuda. Latuda and Seroquel XR are FDA approved for depression, do work, do not destabilize, and are very effective. And so be aware of the use of those two. Symbyax is also approved, but Symbyax is a combination of Zyprexa and Prozac, and not at all very, very popular. Lamictal, widely used in bipolar patients. It's rare that one of my bipolar patients is not on Lamictal or lamotrigine. Why is that? First of all, tolerability. Lamotrigine has no weight gain, has no sexual side effects, no sedation, beautifully tolerated. The only negative of lamotrigine, and it's extremely rare, would be a skin rash that, if not addressed, may lead over time to fever, swollen lymph nodes, and could even lead to a severe condition called Stevens-Johnson syndrome. And thankfully, I've never had a single patient have that, and most doctors have fortunately not seen that. It's theoretically possible, but not typically real common. So well tolerated, generic and inexpensive. But lamotrigine is much better at protecting a patient from depressive episodes than manic episodes. And bipolar patients, even though they've got to be manic at least once to be diagnosed as bipolar, they're depressed much more of the time. The depressive part of bipolar disorder lasts longer and is more negatively impactful on the quality of their life than the hypomanic or manic parts. And being on lamotrigine over time will help to protect them from that slide down into depression. And lamotrigine may not be enough by itself, but so many of them, if not most of them, are going to be on that, and you're going to see lots and lots of your clients taking lamotrigine or Lamictal. At the bottom of this slide is all the medicines that we typically used for the manic part of bipolar disorder. Lithium carbonate was the first medicine years ago, and then it kind of went out of favor a little bit as we prescribed lots of Depakote and Tegretol. But you need to know that lithium has come very much back into favor again. Why? Because it works so well. It's very inexpensive. It does require some blood monitoring, as I mentioned earlier, but incredible in terms of its activity. The biggest problem I have with lithium is people say, oh gosh, I've heard bad things about lithium, or that's the big gun, or people are going to look at me funny if I'm on lithium. And those are issues that we have to address and think about and talk about. But in terms of efficacy and usually tolerability, still a very, very appropriate medicine to prescribe for a bipolar patient who's manic, or to protect them from manic episodes over time. Because Depakote and Tegretol are effective bipolar medications, a lot of people thought, well, gosh, maybe the other anticonvulsant medicines, anti-seizure medicines, like Topamax or Neurontin or Gabapentin or Keppra might also be effective agents. And the bottom line is that they are not. You might see some of your bipolar patients on topiramate or Topamax, but not for its mood stabilization properties, but for its weight gain properties. Topamax blocks or blunts weight gain. Mechanism is not clear, but it was originally a seizure medicine, came out 20 years ago, and most people who took it for seizures began to lose weight. We want to treat bipolar disorder to remission, just like we treat depression to remission. I don't want my bipolar patients to have fewer mood swings. I want them to have no mood swings. And again, we know that can't always happen, and that can be very, very challenging, but that's still what we want to try to target. And that's why we get into often the issue too of so-called polypharmacy. Polypharmacy being defined as being on 2, 3, 4 psychotropic medicines instead of 1. Polypharmacy years ago used to be a dirty word, and these days it's the standard of care. Why? Because we're trying to treat most conditions to remission. And remission, we defined earlier, often means hitting different neurotransmitter systems. And I may have a bipolar patient on 2 mood stabilizers, but they can't sleep, so they need to be on a sleep medicine. And then 60% of bipolar patients have lots of anxiety along with their bipolar disorder. They need to be on buspirone for the anxiety. So buspirone for the anxiety, Ambien for the insomnia, and then lamotrigine and maybe Latuda for mood stabilization. That's polypharmacy, but we're hitting the heterogeneity of their symptom picture to get them into as good a response or remission as we can and return them back to normal functioning. As I tell every bipolar patient, if you start not sleeping, get in touch with me immediately. One night here and there, of course, can be something we all go through, but 2, 3, 4 nights in a row, very important to pay attention to in bipolar disorder, because that either is an indication that they're about to go into a mood swing of one sort or the other, or it may even actually be a cause of the mood swing. So insomnia, sleeping well, very important in terms of mood stabilization. Metabolic syndrome. Metabolic syndrome is defined as weight gain, hyperlipidemia, increased cholesterol, triglycerides, hyperglycemia, increased blood sugar. Sadly, those are 3 side effects of many medicines that we prescribe to treat particularly bipolar disorder, and obviously can be a major factor in the choice of those medicines. You need to know, though, that many bipolar patients have metabolic syndrome as part of the illness itself. In fact, several epidemiologic studies have shown that up to 50% of bipolar patients, before they're ever put on any medication, may have metabolic syndrome, something about the illness itself that predisposes to that. All the more reason why we don't want to then pick a medicine that's going to add to weight gain, add a negative impact on their lipids and blood sugar in the course of treatment. And there are some that are much less likely to do that. Latuda, for instance, which we mentioned earlier, approved for bipolar depression, very close to weight neutral, very close to neutrality in terms of hyperlipidemia, hyperglycemia, huge plus in that respect. Ziprasidone or Geodon, another of that class, very close to being weight neutral. So many bipolar patients, of course, do abuse alcohol and substances and may need that addressed as part of their treatment, not just being on medicine, not just having therapy, but also to get off of whatever substance they're using. People often say, well, gosh, I'm drinking because I'm bipolar, and so I'm going to keep on drinking until you get my bipolar regulated. And our current data suggests, no, that's not the way it works. We got to get you off the alcohol before I can treat your bipolar, because I don't know what's the alcohol, either intoxication or withdrawal, and what's your bipolar. Also, as long as alcohol is in your system, I can't assess the impact of medicines one way or the other. They've got to become abstinent first. Then you treat the bipolar, then you treat the depression, then you treat the anxiety disorder, whatever it is. So patients abusing alcohol and substances have to be treated for that condition first. Then you can address the underlying mood disorder. Sometimes we even find the underlying mood disorder, quote, goes away. It really was a reaction of the body and brain's part to multiple substances being abused over time. So that's an important consideration to be aware of as well. Psychotherapy in bipolar disorder. Bipolar disorder is a biological illness. It's genetically programmed. It runs in families. It's fascinating to look at all that data, and there's no doubt about it whatsoever. So whether you are bipolar and whether you have a mood shift is biologically determined. But what we found is that when you have a mood shift, may be psychosocially determined. And that's where psychotherapy counseling comes into play. It's so important in terms of treating bipolar patients. They may be on a good medication regimen and reasonably well controlled in terms of their symptoms, but if they have still ongoing stress in their marriages, in their lives, that's going to basically sabotage and undercut the medication regimen. And that's, of course, where many of you will come into play, making sure that patients are getting adequate psychological counseling or attention to the social issues in their life. I've got now, and I say this every year, Rick, but I've got a number of high-functioning patients who I've been seeing for years, who take their medicine, whose mood is nicely stabilized, and they're back at work, in many cases pillars of the community. But when they come back to see me, they say, I still want you to know I'm going to take your medicine because my wife said she was going to divorce me if I didn't, or my boss said that he was going to kick me out of the company if I didn't. But I think you're wrong. I still don't think I have bipolar disorder. I'm just smarter than other people. I have more energy than other people. I'm more creative than other people. I'm better looking than other people, whatever. That denial is often right at the core of this illness, and that doesn't necessarily respond to medication. But it's important to be aware of it, because think about it. If you are taking a medicine, even going for therapy, but you think it's basically just you're going through the motions to pacify other people, you may then be a real high risk of non-compliance, of veering off into saying, I'm not going to do that anymore. So still constantly try to drive home the point that your denial, the fact you're sitting here saying you don't have it, that's proof that you do have it. That's a symptom of the condition. All that's happened in your family and in your workplace, thanks to your impulsivity and so on, is indication that you do have it. But bipolar patients love the adrenaline rush of being bipolar. Another reason they don't take their medicines. They love being energetic. They love being creative. They love the high that they have. And when they come back down to where most of the rest of us are, they experience that as flat or even being depressed, even though they're really like the rest of us, and they miss that high. And then another obvious issue in terms of compliance. A reasonable first treatment for anybody with an anxiety disorder, whether it be panic disorder, generalized anxiety disorder, post-traumatic anxiety disorder, would be to prescribe a serotonin antidepressant. But you're prescribing it if they have just anxiety and not associated depression. You're prescribing for the serotonin activity, which, as we said earlier, is very effective against anxiety. And this is important to know, because many patients will say, I don't have depression. I'm here because of panic attacks, and you want to give me Celexa or Lexapro. And the answer is yes, because the serotonin effects of Lexapro are very good against anxiety. And they say, well, why is Lexapro called an antidepressant? And the answer is back to the FDA. The first indication that Lexapro was approved for was for major depression. Then the company went on and also found that it was very effective against generalized anxiety disorder as well. But that often doesn't get out into the public as much. They think of these medicines as antidepressants, forgetting that many of them, actually most of the serotonin antidepressants, are very good against anxiety as well. And obviously another reason to prescribe them as a first choice for the anxiety disorders is that they are not benzodiazepines. They're not controlled substances, and some patients are fortunate enough to have their anxiety symptoms under control with an SSRI or SNRI all in and of itself. But what about the benzos? The benzos, as you all know, are these medicines here, the Ativans, the Xanaxes, the Klonopins, and so on. Several bits of tracking data have shown that probably well over 50% of patients with anxiety disorders who are treated to remission are on a benzodiazepine and an SSRI, or a benzodiazepine and an SNRI. And why? Again, because we're trying to treat to remission. The SSRIs, though, are a huge help and actually a cornerstone of the treatment of generalized anxiety disorder, panic disorder, may not in and of itself be enough to get the symptoms under adequate control. So having a patient on twice daily dosing with clonazepam or Klonopin with their Lexapro may be necessary. So what about the issue of long-term use? Lots of people say, well, gosh, I looked on the internet and so you shouldn't use Klonopin longer than 3 weeks. There are 2 or 3 things about that. First of all, when these medicines are studied before they get FDA approval, the studies often last 3 weeks, 6 weeks, 8 weeks, and that language may get into the package insert that this medicine was shown to be effective against anxiety when used for a period of 6 weeks. But anxiety for most patients is a lifelong disorder, just like bipolar disorder is, just like recurring major depression. So it can be appropriate to be on long-term benzodiazepines for a lifetime, as long as a person is taking it appropriately, not doctor shopping, not escalating the dose, not asking for early refills, not taking it recreationally, not selling it, and not abusing alcohol or substances with it. And that's a lot of stuff. So that means a very careful patient selection process, because benzos obviously can be abused, are abused, especially the short-acting ones like Xanax. Xanax may be appropriate for short-term, periodic, situational anxiety because it just lasts for a short time and hits you hard. But for the long-term treatment of anxiety, I'm not a fan of Xanax because of that roller coaster effect. It lasts about 6 to 8 hours in your system, so 3 to 4 times a day dosing of Xanax to get anxiety under control. Klonopin or clonazepam, which has a 76-hour half-life, much smoother and more even and more likely to give adequate anti-anxiety control over a longer period of time. So Klonopin is probably my favorite benzodiazepine because of that long duration of action and the fact that it's that you can miss doses and not experience either withdrawal symptoms or breakthrough anxiety. It's not that hard to taper off of, and it's almost never abused. So clonazepam widely used for that very reason. Buspirone came out about 15 years ago as an anti-anxiety agent, generalized anxiety disorder. And everybody was thrilled. So, gosh, here we have a non-benzodiazepine anxiety medicine, and everybody flocked to it. And then within months, there was huge disappointment because it just did not seem to be very efficacious. In fact, the old joke about Buspirone was it had everything you wanted in an anti-anxiety drug except efficacy. And we've now learned, looking back in retrospect, that the reason for that perception was underdosing. 15 milligrams twice a day of Buspirone, which was the original recommended dose, we now know is woefully inadequate for many anxious patients. Most of my patients are on 30 twice a day, sometimes even 45 twice a day, still beautifully tolerated, not a controlled substance, you don't have the benzo concerns, and so very effective for generalized anxiety symptoms. Also can be used as an antidepressant augmentation agent as well. And PTSD is a little tough because PTSD, almost by its definition, there are biological changes that the release of norepinephrine and the release of steroids from the adrenal gland and the brainstem when a patient was exposed to an overwhelming trauma changes the brain. It basically brands the brain in a way that causes flashbacks, nightmares, recurring symptoms, and so on. And so many PTSD patients do need medication. One thing would be to see is your patient responding to talk therapy and psychological intervention? If they can use relaxation techniques, if they can use cognitive techniques to divert themselves away from a lot of the PTSD symptoms, and the symptoms themselves are not severe and disabling, they may not need medication. That would be a milder form of it. The more prevalent and intense are the physical symptoms, as in breaking out in a sweat, breaking up in the middle of the night, not being able to sleep through the night. With PTSD, the more likely they are to have that biological piece. And that's easier with depression rather than PTSD, because with depression, the biological symptoms are the weight, the sexual side effects, the sleep, the energy. Those are physical symptoms. Some depressed patients say, no, my energy's okay, I sleep okay, I'm just negative, I'm sad all the time, I don't enjoy things. Those are psychological symptoms. And those might be targets of psychotherapy, but the more they get into the weight changes, appetite changes, and the other things, the more they may need medication to get that part under control. Collaboration between social workers and prescribers would be psychiatrists, primary care doctors, nurse practitioners. If your patient is getting his or her medication from a prescriber, I think it's very important to reach out and try to have collaboration. I'm sure everybody here may have multiple stories about, I never got a call back, he or she didn't want to talk to me, didn't see it as worthwhile, and so on. It's always worthwhile, and it's always worth the effort. You're going to obviously find clinicians on a spectrum of those that welcome it, eager to do it and do it on a regular basis, others that don't see the value in it. If you've reached out to a prescriber and he or she is not responsive, you might ask your patient, your client, when you go back and see the doctor prescribing your medicine, ask him or her, would they please give me a call? Would they be willing? Because the patient may have more clout than you just calling up yourself out of the blue. And of course, these days we have HIPAA and confidentiality issues as well, so there may need to be signed agreements. But I just find it tremendously helpful. Every time I talk to the therapist, whether it's a social worker or psychologist, I learn stuff that I just didn't know. I'm seeing the patient maybe for 20-minute med checks. The therapist is seeing them for 45, 50-minute sessions. I'm seeing the patient once a month. They're often seeing the patient once every week. There's always lots that I can learn in terms of adjusting my medication. And I might also be able to put into perspective some things that the therapist might also be able to address based on symptoms I've seen or issues that have come up with the medication. So that should be the standard of care, and it is the standard of care, but we often fall woefully below that, sadly. First of all, in tapering off one and tapering on to another, I always tell everybody, you may feel worse before you feel better. So first of all, just to legitimize that so that they don't automatically assume this means my new medicine is not working. I'll say, even though we're stopping the original medicine, we're stopping it because it wasn't doing enough, but it was doing something. So you're going to lose that before you get the kick into the new. And everybody knows that all antidepressants sadly take 2, 3, 4 weeks before they start to work. So that can be a very vulnerable time. And I'll often say, as we do this, I personally, I always ask for a phone call or an email in 1 week. I want to just hear from you. I don't say, give me a call if you have a problem. I say, give me an update in a week. And just having that little touch base point often helps them feel better that they know that They say, I'm hanging in there, I'm doing okay. And just availability to you or to the prescriber can be very important until they make that transition and get through it. And that's another reason, though, it's important to do it gradually. You almost never stop medicine 1 and start medicine 2, because then you get a definite falling like a rock of the blood level and a return of symptoms abruptly. Do it slowly. And most prescribers know that and should do that, but I mean, you never know what you're going to see. So.